This program is brought to you by Emory University.
All right, good morning, everybody. Welcome to Friday morning conference. Our speaker this morning is, as you can see, Dr. Melroy D'Souza, one of our first year clinical track fellows. Melroy did his undergraduate studies at Lafayette College in Pennsylvania and did medical school at Robert Wood Johnson in New Jersey. Did his residency here at Emory and was the chief resident at Emory University Hospital last year. He is going to discuss a topic near and dear to my heart this morning, hypertrophic cardiomyopathy. Take it away, Melroy.
Okay, thank you, Dr. Williams, and thank you everybody for making time this morning to come here to my talk. The topic today will be hypertrophic cardiomyopathy, and we look at emerging therapies and promise for the future. I have no disclosures. So the objectives of the talk, there's a lot to cover, but we'll talk about the pathophysiology of HCM and really highlight the phenotypic heterogeneity. We'll talk about current management strategies with the guidelines, but then also we'll end with ongoing clinical trials for new agents that are here. The scope of this talk won't really talk about sort of lifestyle management, lifestyle warnings that we give to patients or indications for ICD. As you'll see, there's a lot to cover, and those are good for another talk as well. So we'll start off with 3 patient cases to really highlight the unique presentations of this disease, and then that'll be a segue to the rest of the talk. So the first patient is a 47-year-old gentleman. He has an apical variant of HCM, OSA, hypertension. This was actually picked up after a preoperative screening, surgical screening with an EKG that we'll look at. He was known to have an apical inferior septum that was 1.9 centimeters thick. He had an elevated mid-cavitary gradient, but not an LVOT gradient, and we'll talk about that distinction. But because of this, he was determined to be a non-obstructive hypertrophic cardiomyopathy physiology. He had progressively worsening symptoms of heart failure. He was not able to tolerate calcium channel blocker in the past, and he can only tolerate a low-dose beta blocker now, and he gets fatigued with higher doses. So this was his for that screening EKG I talked about. Just the big takeaways: normal sinus rhythm, and is that you could pick out signs of LVH, so that warranted him to get an echo. And this was an echo more recently, not right back in 2010, but as you can see, he has some thickening over his interventricular septum, his posterior wall. But as you get to that short axis view and look at the apex, you can start to appreciate how thick his apex is, and his apex is asymmetrically thick compared to the rest of the myocardium. This is the Doppler signal looking at the peak pressure gradients or the mean pressure gradients. But notably here, this is the pressure gradients in the mid-LV cavity and not in the LVOT or the outflow track. So because of that reason, he's non-obstructive physiology. And here is just a strain pattern, LV strain pattern. As you can see, it's sort of this inverse amyloid characteristic pattern where, amyloid we think about cherry on top, but here his biggest defect is in the apex and surrounding septal regions, which also goes into his apical predominant hypertrophic cardiomyopathy phenotype. So on follow-up, recently, the patient continues to have NYHA class 2 and 3 symptoms, mostly exertional dyspnea. He's only able to tolerate low dose of atenolol, and he's tried other beta blockers and does not feel well with them. He's frustrated, understandably, about his lack of options and his persistently poor symptoms. And for him, we've discussed possible apical myomectomy with, particularly at Mayo, one of the few centers that does it, or an off-label enrollment in one of our clinical trials. And we'll see why these are options for this patient later on. Our second patient, young gentleman, 35-year-old man, history of HCM that was diagnosed at age 10. He was previously taken care of at Boston Children's, has had all the complications of hypertrophic cardiomyopathy that we'll hit on, a very sick person. He has an ICD, upgraded to a CRTD, and then now he's developed borderline dilated cardiomyopathy with RV dysfunction, so really heading towards end-stage heart failure. This is actually a slide from Dr. Byland's grand rounds that she gave, but as you can see, this patient primarily has asymmetric septal hypertrophy. I know now I mentioned that he's sort of borderline dilated, so his echo parameters have changed over time, but earlier on in his disease course, he did have ASH, as you can see here with this asymmetric hypertrophy. This is his strain pattern. Compare that to the last patient who had central sort of clearing around the apex, but this patient had sort of extensive myocardium involvement of hypertrophic segments, and his apex is relatively spared. So this is sort of that cherry on top. Do not be confused with, thinking that this is an amyloid pattern. This is somebody who's had kind of progressive hypertrophic disease that leads to this strain pattern. And here's just a 3D rendering of this long axis view showing the septal thickening. Okay, so then this patient, he's now that he has advanced heart failure, we think about goal-directed therapies for him, but unfortunately, he cannot tolerate beta blocker, cannot tolerate Entresto. The only medications that he's on right now is low-dose lisinopril and ivabradine. He has persistent NYHA class 2 symptoms. Biggest driving symptom is fatigue. And he is now established with the Advanced Heart Failure Clinic to begin discussion for advanced therapies. So again, very sick gentleman. And I presented 2 cases to you, and I don't want to cause you to be sad and depressed about HCM early on a Friday morning. So we'll wrap up with patient 3, who has some promise here. He's 67, history of hypertension, mild AS, CAD status post PCI in 2018, who was diagnosed with hypertrophic cardiomyopathy in 2021. His phenotype is the asymmetric septal hypertrophy with the max width of 1.8 centimeters seen on MRI. On echo was closer to 2. He developed fatigue and dyspnea while walking up his stairs in his house. So he's coming in the clinic kind of complaining of NYHA class 3 symptoms. Found to have an LVOT gradient of about 80 millimeters per mercury post-Valsalva, so he meets criteria for obstruction. His Holter was negative for arrhythmia, and he's initially treated with a beta blocker. This is a sort of pictures from an analogous patient, just that has better echo images to show, but really the clinical course is pretty simple. So as you can sort of see here, his interventricular septum appears thickened, particularly compared to his posterior wall. And then we see maybe that sort of described a little bit better on the short axis view and on the apical view as well. And I understand that this is a bit harder to see, but ultimately his post-Valsalva pressure gradients in the LVOT is as high as 162 millimeters per mercury. So very, very high LVOT gradients. So, this patient comes to clinic, he's having high gradients, he's having very, very bad symptoms. So what can we do for him? So just 2 months ago, he was started on a novel myosin inhibitor, and we'll talk about what that is later on, 2 months ago. And he comes in this month, actually, and he said that he's now able to play golf, and he's able to walk around his house or around the neighborhood with minimal dyspnea. So his symptoms have gone from class 3 to class 1 in 2 months, which is really incredible. So that sort of just sets up the way for the rest of our talk here. And then his follow-up echo, this was actually done, 2 months after, actually 1 month after him starting on the novel myosin inhibitor. And as you can see, his myocardium still remains thick, but his resting gradient and his post-Valsalva gradient have remarkably decreased by more than half after starting this therapy for just 1 month. So now let's just talk about the disease briefly, the history and diagnosis of HCM. So it was first described really not that long ago in 1957 by Dr. Donald Tier in London, who wrote about 8 cases of asymmetric septal hypertrophy that he noticed on patients with autopsy that he didn't expect to have cardiac disease. Then a couple of years later, Drs. Morrow and Braunwald also reported some findings of patients who were now undergoing open heart surgery and looking at gradients and hypertrophy in those patients. And really what started to kick it off was this case series also published by Dr. Braunwald in 1964 with 64 patients with a similar condition, which at the time he called idiopathic hypertrophic subaortic stenosis. So how do we define hypertrophic cardiomyopathy? So it's really a morphologic expression of hypertrophy combined to the heart or confined to the heart. There shouldn't be other systemic manifestations because then you think about other disorders at play. And then you look at, you get an echo and you think about this, or you notice this patient has LVH and the absence of other cardiac disease, right? They don't have long-standing uncontrolled hypertension that could explain it. They don't have a metabolic disorder or systemic disease such as sarcoid or amyloid or infiltrative process that's causing a thickened myocardium. So you rule all that out and you notice this finding on echo and you start to think about HCM. So in terms of criteria, they need to have an end diastolic wall thickness of any LV segment over 15 millimeters or 1.5 centimeters. However, in patients who have a family history of this, we have a sort of more stringent criteria. So if they have a wall thickness of over 13 millimeters or 1.3 centimeters, then they meet criteria for HCM. Now, the big distinction once you've diagnosed HCM is to try to figure out if this is non-obstructive versus obstructive, because that has really a lot of weight in how you're managing these patients and also how you're thinking about these patients, about their disease course. Because those who have obstruction are sicker, they have worse symptoms, and they have worse prognosis. So how do we define obstruction? So you need to have LVOT obstruction, as we highlighted the difference between case 1 and 2, if you remember. So LVOT gradient, either at rest or on provocation of over 30 millimeters per mercury, meets criteria for obstruction. So then going into the pathophysiology of HCM, it's primarily, when patients have it, it's a single gene mutation disorder, but there are over 900 genes that have been identified, gene mutations that could lead to this overall phenotype. It's inherited in an autosomal dominant pattern, and really, this is a nice cartoon, but also kind of a scary cartoon with different components of the sarcomere. But what we ultimately care about, this is myosin. This is a myosin binding head, which ultimately binds to thin filaments of actin via these cross bridges. And I know I said there was over 900 mutations that are implicated, but really the two most common ones are myosin binding protein C and beta myosin heavy chain here. Vast majority of patients, I think up to 50 or 60%, have one of these two mutations. And ultimately what that does is that increases the number of cross bridging between actin and myosin, which ultimately then leads to myocyte hypertrophy, cell enlargements. That hypertrophy will cause this disarray in architecture and this disorganized pattern, which will then lead to interstitial fibrosis, and then on a macroscopic level lead to endocardial fibrosis, which then we start to pick up on MRIs. Then we think about this causing making patients prone to arrhythmia. So this is sort of the kind of progression of disease and why we get from hypertrophy to fibrosis in HCM. In terms of phenotypes of HCM, what we might see on echo, it's a heterogeneous disease. So this is a nice sort of figure on UpToDate, actually, that goes over several different phenotypes. So here, this is normal myocardium. In B, this is two of the cases that we talked about with asymmetric septal hypertrophy, or ASH. C is this primarily basal septal hypertrophy, or sigmoid septum, that we see not infrequently. Group D is this sort of mid-cavitary thickening, which leads to this obliteration of the mid-LV cavity. E is not a very common phenotype, this primarily lateral wall hypertrophy, but it is possible, I suppose. G is an apical variant, so apical variant HCM. As you can see, the apex is very thick here, making the overall cavity small. And then some other variants here, such as right ventricular hypertrophy is seen in I. And then an F is really sort of that dilated, thinned out walls and sort of end stage of presentation. So, what are our patients going to tell us? What are clinical manifestations? So by and large, what we care about preventing and what we care about treating is symptoms of congestive heart failure. And that primarily comes from a few different factors. Diastolic dysfunction from the thickened myocardium that has impaired relaxation. It comes from LVOT obstruction, particularly when these patients are trying to exert themselves, their obstruction gets worse because of increased sympathetic drive and increased inotropy. These patients will develop mitral regurgitation, either from long-standing diastolic dysfunction leading to MR, or we know of systolic anterior motion of the mitral valve that causes this obstruction, also tends to pull the leaflets apart and causing some MR. So that can have heart failure symptoms. And then ultimately, when these disease progresses, particularly like in patient number 2, you can have systolic heart failure symptoms kind of at play, which also plague these patients. They might tell you about chest pain, which we'll go into detail in the next slide. They can complain about syncope. We think about young athletes who have HCM and having either malignant arrhythmias or having syncope. And the syncope comes on from a couple different mechanisms. One is, you think about post-exercise LVOT gradients are the worst. And it's probably a combination of things as decreased preload, really high inotropy, really high sympathetic states. So during and in the end of exercise, the LVOT gradient is the absolute highest. So it makes patients at really high risk for developing syncope. And then, of course, you also have comorbid malignant arrhythmias that come in with patients with HCM, which can lead to syncope and then sudden cardiac death. And atrial arrhythmias, particularly atrial fibrillation, is also something that troubles these patients because of longstanding diastolic dysfunction, MR, so on and so forth. So where does chest pain come from? So if patients have particularly just HCM, it's not really coronary stenosis as we think about for angina and chest pain, but it's really a microvascular issue, which is comes into this imbalance between increased myocardial oxygen demand and reduced myocardial oxygen supply, essentially. So there's an increased demand because these cells are big, they're hungry, they work really hard. So there's an increased demand. There increased wall stress and increased LVOT obstruction gradient, and this drive to increase inotropy will increase myocardial demand. However, we don't have the supply to match that. And why is the supply reduced? Because if you just think about the hypertrophy and these cells getting bigger, it makes for these smaller blood vessels, it kind of makes their course much farther or much more difficult for blood and oxygen to traverse. The distance between the epicardium and the myocardium tends to increase with this interstitial fibrosis, with these cells getting bigger. So just physically, there's a barrier for blood and oxygen to get there in adequate time. But then also there's comorbid endothelial dysfunction, impaired vasodilation, which then also leads to an impaired O2 supply. So the chest pain, exertional chest pain, is driven by this mismatch here, and not quite by coronary disease. But of course, as we saw in patient number 3, he had coronary disease sort of before he was diagnosed with HCM, so they're not mutually exclusive. So how do you diagnose HCM? Really imaging and really echo is the way to go. So echocardiography can help you establish diagnosis and which one of those patterns, if you remember that up-to-date slide of pattern of hypertrophy. The Doppler technology has gotten so good that we can actually use that to quantify the severity of gradients. If your rest echo is sort of equivocal, or you're not getting good Valsalva readings, then you can do a stress echo to really elicit how severe the gradients are. You can look at the mitral valve, look at the apparatus, the presence of systolic anterior motion of the valve, presence of MR, and then evaluate initially for diastolic dysfunction, and then later disease, look for systolic function as well. Just a couple stills. I know probably our videos were more instructive earlier on, but a couple still images of echocardiography. You see here this anterior septal primarily involvement of HCM, and you have some thickening of the inferior and posterior walls as well. And you can see that on the 2-chamber apical view. And then additionally, besides just looking at the walls and measuring the walls in 2D, you have Doppler technology that helps you determine your gradients, such as here, helps you determine diastolic dysfunction. So echocardiography really for places that don't have a lot of resources, but also have good resources like we do. Echocardiography is a really good test that tells you a whole lot about the disease. There's also MRI. MRI for diagnosis is helpful if you're thinking there's HCM and you really can't get good views of certain areas, and those areas are the apex, posterior septum, and anterolateral walls that sometimes you just can't get really good resolution on an echo, but your suspicion is high. You can follow that up with MRI to really confirm, okay, do I have hypertrophy in these segments? Further than that, it helps with prognosis by determining extent of myocardial fibrosis, because we know more fibrosis increases the risk for heart failure symptoms and certainly increases the risk for ventricular arrhythmias. And then for patients who need septal reduction therapy, which we'll describe what that means later on, it's great for pre-procedural planning. Look at the anatomy before kind of deciding the procedural course. Some examples of MRI here. So this patient has asymmetric septal hypertrophy, which I think you can see really nicely here in the apical view and in this short axis view here. And then in D and E, it's really describing that late gadolinium enhancement, which indicates high degree of fibrosis in these areas here. So MRI can give you a lot of diagnostic and prognostic information as well. So it's a helpful tool to have. And then there's catheterization. It's not really in the armamentarium for diagnosis any longer. But if you're not able to get good gradients on an echo, or the patient's getting a catheterization for other reasons, there are some things that we can find on catheter. Particularly when we're in there, it's helpful to do provocative maneuvers. So on the table, the patient can do Valsalva. Under the drape, they can do upper or lower extremity exercises to again increase inotropy and try to elicit that gradient. You can induce PVCs, and there's a cool finding that we'll talk about in the next slide, or you can get them isoproterenol infusions. And here's some tracings, aortic and LV tracings that help you kind of just determine, okay, I noticed some pressure gradients across the aortic valve. Could this be from AS, or could this be from a dynamic obstruction like hypertrophic cardiomyopathy? So on the left here, you see sort of the findings in something like severe AS. So you have a fixed obstructive defect. You have sort of uniform filling of the aorta across the aortic valve, and really you have this late peaking pressure in the aortic valve at the very end of systole, which this actually represents severe AS. Whereas in a dynamic obstruction, like in HCM, what you see is this very rapid early filling across the aortic valve into the aorta. And then you have sort of, because the LVOT obstruction gets really bad in sort of mid to late systole, you have almost, a cessation of flow across the aortic valve. So that's what you see here, that very rapid increase of filling across the valve, and then really not too much else after that. That happens in early systole. And that makes you think about a dynamic obstruction. Then, what you can also see, and I was fortunate to see this in the cath lab too, is the Braunwald-Morrow sign, or just for short called the Brockenbrough sign. What it is, it's this post-PVC augmentation of systolic pressure in the LV, which then really makes your gradient worse. So this is the tracing peak to peak between the LV and the aortic, in the aorta, sorry. And maybe they have a resting gradient of around 30 here, so sort of borderline for obstruction. And then the patient has a PVC. There's a physiologic pause, increase in diastolic filling time, but also an increase in inotropy, which is a physiologic phenomenon. And then the next sort of beat, your LV systolic augmentation pressure just goes way up, but then that increase in inotropy really increases your LVOT obstruction, which then decreases your pulse pressure in the aorta itself. So you see not only like a widening of the gradient, but you see the aortic pressure get lower, the LV pressure go way high, and that only happens really with this LVOT obstruction and HCM. So that can be helpful, but again, catheterization is not, needed for diagnosis of this condition. So the rest of the talk, after a little bit of background, we'll spend on medical management, current guidelines, and new therapies. So traditional therapies, beta blockers, calcium channel blockers, and disopyramide. So beta blockers are first line. They are nice because they can be used in patients with or without LVOT obstruction. Same thing with calcium channel blockers. However, they improve patient symptoms. The goal is to decrease inotropy, increase diastolic filling time to help patient symptoms, but it doesn't do anything for disease course, okay? And as you see, patients are young with this disease. Patients have intolerance to beta blockers. You have intolerance to calcium channel blockers. We saw some of those with our patients that we started off the talk with. So there are these therapies, but they're either not really well tolerated, you cannot increase their doses a lot, or patients, just don't have a lot of success on them. Then if you've given a trial of beta blockers, calcium channel blockers, or both really, and the patients are still having persistent symptoms, the guidelines say it's reasonable to add disopyramide. As a reminder, it's a 1A, class 1A antiarrhythmic, primarily, for this disease works as a negative inotrope. And in opposition to beta blockers to calcium channel blockers, it is shown to decrease rest LVOT gradients. The first two do not. But it is an antiarrhythmic, primarily works on the IKR channels, so you are at risk for QTC prolongation. So if patients have had sort of middle ligament arrhythmias before, torsades before, you're really limited and you cannot use disopyramide. And we'll go over the guidelines, but the other therapy then, once patients are on these medications are still having class 2 to 3 symptoms, the next step would be surgical myomectomy, which is a surgical approach, sternotomy-based approach, versus alcohol septal ablation, which is a catheter-derived procedure for really reduction of that hypertrophy and mass. So these are the 2020 ACC/AHA guidelines for HOCM, so patients with hypertrophic cardiomyopathy with demonstrated obstruction. So if they're sort of in the class 1 area where they're not really having any symptoms, it's reasonable to have them follow up and not have them start on any therapies. But when they develop class 2 symptoms, that's when probably the first medicine you're grabbing for, first class, is the beta blockers. And then, you can, they're not tolerating, switch to calcium channel blockers, keep them on a low dose beta blocker, and add a calcium channel blocker if their heart rate and blood pressure tolerate it. And I didn't mention this on the other slide, but we do non-dihydropyridine calcium channel blockers, so verapamil and diltiazem. And so symptoms persist, then you can add disopyramide or start to think about septal reduction therapy. If they are not a surgical candidate, you do a catheter-based septal ablation. But if they're a safe or reasonably safe surgical candidate, then you think about myomectomy. These are right from the guidelines for HCM without obstruction. And I didn't post the exact guidelines for obstruction, but I will tell you that what's available for non-obstruction is so much less than for obstruction. So really the best indication is, okay, for patients who start to develop symptoms, they have a preserved EF, start to develop symptoms, you can add beta blockers or calcium channel blockers for them. But everything else is it's a suggestion and it's reasonable to use, but the evidence for it's not great. So since patients with non-obstructive disease don't have that LVOT obstruction, they're not as dependent on maintaining a good preload. It's reasonable if they look like they have volume on them to use low-dose oral diuretics. But again, you have to be very careful with diuretics in these patients. Some, even weaker evidence to try to use ARBs or ACE inhibitors. And then this is sort of interesting. If you remember in patient 1 who had non-obstructive phenotype, he's having bad disease, we were thinking about referring him for apical myomectomy. So that's what this part of the guideline is saying. In highly selected patients, but also in a very highly selected number of centers, thinking about something like apical myomectomy could be a reasonable option, but there's sort of a lot of caveats. And again, the evidence for this is not great, but it's there. So what is septal reduction therapy? So as I said, there's sort of two flavors, surgery versus catheter-based. The guidelines, do talk about septal reduction therapy as being a good option, but it really is with the caveat that it has to be done at a center of excellence, such as Emory. Fortunately, we are one, and there's a handful of centers around the country. But this really is based on volumes, the operator volumes, operator comfort with these procedures, both surgically and on the interventionalist side. So they just can't be done by any hospital. We had this similar discussion like this at Grady, and the attendings were talking about really bad outcomes, seeing really bad outcomes for patients who've had these procedures not at centers of excellence. So, if you're not near a center of excellence, the patient doesn't have access, this is probably off the table. But for those who have access to, our sites or different sites around the country, my surgical reduction or septal reduction therapy is a good option. Surgical myomectomy improves gradients, and then by improving gradients, you're improving systolic anterior motion of the valve, and then also you're improving SAM-mediated MR. So, patients do have decent outcomes after this. Alcohol ablation is sort of head-to-head, a little bit worse than surgical myomectomy, but still does well for patients, but it becomes less effective when the gradients are really high or when the wall thickness is really great too, over 3 centimeters typically. It's important to note though, SRT, it sort of like debulks in a way, but it doesn't alter the disease course. So patients are at risk for developing heart failure or advanced heart failure, developing AFib. So, once patients are there, it's not like they have a curative therapy. This is sort of just a measure to try to help them out, but it's not slam dunk. So the treatment summary of what we have so far and what's in the latest edition of the guidelines, medical treatment is there, but clinically, it's not often well tolerated. You're not able to get a lot of efficacy because you can't sort of increase uptitrated doses as much as you might want to. Septal reduction therapy is mostly reserved for obstructive phenotypes, but as we saw, this may be an option in non-obstructive, but primarily is restricted to centers of excellence. So many patients, like patients 1 and 2, are like caught in the middle without good options, with end-stage disease. So, up to this point, there was no FDA-approved treatment for HCM. So, there's a big need in this field. So then that kind of sets the story well for mavacamten, which is the new kid on the block. So what is mavacamten? It's an allosteric selective and reversible inhibitor of cardiac myosin ATPase. That's like a biochemistry word soup, which we can break it down. So allosteric basically just means a molecule that binds to a particular binding site and changes the action of a protein. And the protein that is of interest here is myosin ATPase. This myosin actin cross-bridging is an energy-dependent process driven by ATP. So what myosin does is it binds to these ATPases, doesn't let that energy conversion happen. So over time, with HCM, they have increased cross bridges. Over time, we see a decrease in the number of cross bridges in patients with these novel myosin inhibitor. And the other, I think probably the most important word in this phrase is reversible. And we'll talk about why the reversibility is a very key component of this drug. Overall, it promotes relaxation and decreases LVOT obstruction. Half-life about 8 days, good oral bioavailability, and mostly renally excreted. So now we'll go through a series of trials that really brought mavacamten to fame and then ultimately to FDA approval. So the first one was Pioneer HCM in about 2018. The study was reported. It's a small phase 2 trial. Again, phase 2 trials are just saying, does this medication work in the way that we think it's going to work? And then are there doses that are effective and safe for patients? So before large trials, phase 2 trials try to answer those questions. They're usually small. As you can see, this trial has only 21 participants. They were split up into two groups. One group had higher doses of mavacamten without other therapy. Another group had lower doses of mavacamten and continuation of their baseline therapy, calcium channel blockers, beta blockers. They usually don't combine mavacamten and disopyramide. The primary endpoint here is looking in a change in post-exercise pressure gradient from baseline. And then some secondary endpoints that they looked at, just did the gradients go down under an absolute value of 30? Was there a change in patient-reported dyspnea score? Was there a change in PVO2 max, which is really a surrogate for exercise capacity, resting and Valsalva gradients, EF, and the drug reversibility effect that goes into safety and also just reversibility of any adverse effects that might come on. And then some exploratory endpoints, changes in NYHA class, the Kansas City Cardiomyopathy questionnaire, which is really, with cardiomyopathy, the patients take this questionnaire in different domains. Higher the score, meaning less severe their symptoms, meaning they're doing better. So higher scores are good. And then NT-proBNP, which is really a surrogate for thinking about wall stress. So a lot of numbers and data on the slide, a summary of the results of Pioneer. So their primary endpoint, looking at the post-exercise LVOT gradient. So cohort A, again, was the higher dose mavacamten group. Cohort B was the lower dose group. And as you can see, the higher dose group had also a higher change or decrease in baseline of their LVOT gradients. The lower dose group also had an improvement, but not quite to the magnitude that the high dose group did. Now, the thing to really catch your eye in terms of adverse effects is that the higher dose group also had a greater decrease in their LVEF as a mean compared to a lower dose group. And we'll talk about that with further trials, and we'll assess that sort of scary finding there. And then the median change in NT-proBNP, really kind of a surrogate of wall stress. We can see that the higher dose mavacamten group had a greater decrease in their BNP compared to the lower dose group. And the other variables, there's not sort of appreciable differences, but again, it's a very small study. So we wouldn't expect to see really great effect sizes in all of our variables. But sort of the takeaway, okay, we know that mavacamten does what we think it's going to do, is relieve obstruction, okay? We think that by doing that, it's relieving wall stress. But because it's a negative inotrope, it's doing what we might worry about is decreasing LVEF. But it seems the overall takeaways is that just plasma concentration dependent decrease in LVOT gradient. So higher plasma concentration, greater decrease in LVOT gradient, higher plasma concentration, greater improvement in VO2 max. I didn't highlight this, but the higher dose group had a greater increase in their VO2, peak VO2, which is exercise capacity compared to the lower dose group. So we think that the higher plasma concentration, the better improvements they get. But then also the higher plasma concentration seems to be a greater reduction in LVEF. So that's the balance that we have to strike here. The nice part here, this is where that reversibility comes in. All of these changes, the benefits and the harm, were reversible after 4 weeks of stopping mavacamten, okay? So, and then with that, the authors reported that they found that sweet spot, that therapeutic window between getting the benefits of relief of obstruction, but then also not dropping patients' EF. So once they found that good therapeutic window, then that really opened the door for the clinical trial of Explorer HCM, which is probably the most notable trial to date in HCM. So this was a phase 3 trial, multi-center, double-blinded, placebo-controlled trial. If patients were on beta blockers or calcium channels at baseline, they could continue it, but they were not allowed to be on disopyramide. The starting dose was 5 milligrams, and there was an up titration at weeks 8 and 14. So the criteria for up titration is they would bring the patients in, look at their plasma levels, make sure they were in this therapeutic window, do an echo, and do basically another assessment of their gradients. If they were within this within this range, they didn't drop their EF, but their gradients hadn't improved, then that would sort of meet criteria to increase the dose. 5, 7.5, 10, 15 is sort of the intervals. But if they started to drop their EF, they would either drop the dose of the drug or stop the drug. Or so the EF changes were really helping dictate the changes in dose. The duration of the trial was 30 weeks, and now with 251 participants. Again, not a large trial, but things that we like to look at typically, but still much larger in the realm of hypertrophic cardiomyopathy. And then their primary endpoint was sort of this either or. So either patients had a 1.5 mils per kg per minute increase in their PVO2, along with an improvement in their NYHA functional class, or they had an even greater improvement in their PVO2 at 3.0, and at least their NYHA class didn't get worse. So if patients met either one of these criteria, then they were noted as meeting the primary endpoint. So they had some improvement in exercise capacity, they had symptomatic improvement in functional class, okay, they met the criteria. Or they had a much greater improvement in their exercise capacity, and at least their class wasn't getting worse. Those patients met the primary endpoint. And then the secondary endpoint was sort of more changes in these variables: post-exercise LVOT gradient, PVO2, NYHA class, the Kansas City questionnaire. And these are variables that we'll see in all of our trials, basically. So this table is really kind of the hallmark summary result table in Maverick and really in HCM, in Explorer and HCM so far. So for that primary endpoint of how many patients in each group, the mavacamten group and the placebo group, met that primary endpoint for that either or criteria, 37% of patients in the mavacamten group versus only 17% of patients in the placebo group met that endpoint. And this was a significant change, significant difference. Now, breaking down that endpoint and seeing, okay, like which one of these criteria did people actually get credit for? Like which one did they meet? So mostly it's patients who met that 1.5 increase in PVO2 with a change in improvement in their NYHA class. So most of them did meet criteria because of that, but still, patients, 25% of participants in the mavacamten group made that more modest jump in their PVO2. And then, some patients met all of the criteria in this primary endpoint, with both a really big increase in their PVO2 and an improvement in their NYHA score. So 20% of patients met both versus only 8% in the placebo group. Then now looking at the actual changes from baseline of these variables. So their post-exercise LVOT gradients, the mavacamten group had a much bigger decrease in their LVOT gradients compared to the placebo group. And, I'm going to be a broken record for the next several slides, but these are all significant findings. Their improvements in PVO2 that we see in the mavacamten group, 65% of patients in the mavacamten group had an improvement in their NYHA class versus only 31% in the placebo group. Changes in baseline in the Kansas City questionnaire, and again, higher the score, the better. So mavacamten group had a greater increase in their score compared to baseline, compared to the placebo group. And then this is sort of a patient-reported dyspnea questionnaire, and you can see at least their severity of dyspnea per answers is better in the mavacamten group. So there are several plots in the Explorer trial, but I just wanted to highlight a couple here. Just to orient you, blue is mavacamten group and red is placebo group. And we can see, the changes in EF, which is what we, of course, are drawing our attention, is, fairly minimal between the mavacamten and the placebo group. Most of the times, patients are starting with an EF of over 70%. It's one of the inclusion criteria, but the mavacamten group didn't quite decrease as a mean based on the EF. That was kind of held throughout all 30 weeks of the study. But then look at these improvements. This is looking at the resting LVOT gradients in the mavacamten group versus placebo. And right at that first visit, you're seeing such a significant improvement in LVOT gradients compared to placebo. And this effect not only continues, but if not, gets a little bit better as time goes on. And similarly, looking at NT-proBNP, looking at wall stress, the mavacamten group maybe started off a little bit higher, probably not significantly higher, but still higher than the placebo group. And right again, at that 4-week checkup, the BNP levels are just so much better compared to placebo. So these results are dramatic, but also very promising and very exciting, because we don't quite see this effect this quickly in many medications. This is a nice kind of colorful graphic to elicit the changes in NYHA functional class between the mavacamten and placebo group. So if you can just have an imaginary line down here, towards the left is the mavacamten group, towards the right is the placebo group. And you can see, at baseline, all patients were either NYHA class 2 or 3 in both groups. But at 14 weeks, now some patients have improved to be NYHA class 1, and then mostly are NYHA class 2, and very small amounts of them are still in NYHA class 3, as opposed to 28% being that way on the start. Then we come to week 30, and that effect continues. So even more patients now are meeting NYHA class 1, still a modest amount in NYHA class 2. And, the class 3 goes up here, but I just think like more patients were actually reporting their NYHA class score compared to here. So I think that's why the numbers in class 3 are higher in this last group. Whereas in placebo, you have some improvements in patients, but not quite to the level of the mavacamten group. So this just highlights also patients' functional status are getting better. Now, for the things that, again, draw our attention is that drop in EF. So 7 patients in the mavacamten group throughout the study, and 2 patients in the placebo group had an EF drop below 50%. Most patients in the mavacamten group, so 6 out of 7 had full recovery in their EF after 8 weeks of not being on the medicine. And then 1 patient did have a drop in their EF, and that was noted to be a complication of an AFib ablation, but they still had some recovery of their EF after the washout period of mavacamten. And then one thing we haven't talked about as a variable yet is a change in LV mass. Sort of doing that, not septal reduction, but doing reduction therapy with this medicine, essentially. So the mavacamten group, they had a decrease in their LV mass, which was much greater compared to the placebo group too. So, kind of a lot of variables being affected positively by mavacamten. So, the Explorer trial was really a seminal trial in this to gain good traction for mavacamten, for the efficacy particularly, and, sort of somewhat comments on their safety. And then Valor was sort of presented earlier this year. And what Valor was saying is that patients who are probably the sickest in this population, so patients who are on what we have as guideline medical therapy right now, they're not tolerating it, their symptoms are still class 2 or 3, and they're so sick that they actually, per guidelines, would meet criteria for septal reduction. Now, before we send them to septal reduction, can we instead put these patients on mavacamten and see if they still need septal reduction? Okay, so the inclusion criteria for all these patients in this trial were they all met criteria per guidelines for septal reduction therapy, all sick patients. Then the primary endpoint is at the end of the study period, at the end of 16 weeks, do they still meet criteria for septal reduction? Because if they don't, that means that they're getting better, primarily from mavacamten, or if they still do, okay, so maybe mavacamten is not as great as we thought based on the Explorer trial. And then the secondary endpoints, it's the same variables that we've been talking about in the Explorer trial. So we'll kind of see if those results are able to replicate in this study here. So things to draw your attention to. So this primary efficacy composite point, just again saying at the end of the trial, do these patients still meet criteria for septal reduction? The mavacamten group, only 18% of patients still met criteria versus almost 77% in the placebo group. I will like to take out these 2 patients in each group who opted for septal reduction therapy anyway. So really the denominator does not include these patients. So we'll look at sort of the SRT eligible based on guideline criteria. We'll look at this box here. So even less patients, so even a smaller proportion, 14% of patients in the mavacamten group versus 70% of patients in the placebo group met criteria for septal reduction therapy at the end of the study. So this is saying that, hey, the intervention of mavacamten can, allow a patient to get better without septal reduction therapy, without needing surgery, without needing access to a center of excellence. So this medication actually can help patients, but also prevent sort of, disease progression, hopefully, in a whole bunch of patients that did not have these options before. And then, not to sort of belabor the points, but I'm sure you probably have taken a look at these numbers. All these improvements from baseline in the mavacamten group compared to the placebo group are similar to Maverick, somewhat similar to Pioneer, where you see improvements, just dramatic improvements in the mavacamten group compared to baseline and compared to placebo. So, I'm sort of sounding like the salesman, and I'm telling you about all these great things at mavacamten, but let's get back to the EF, right? I'm sure that's on everybody's mind. Well, we're dropping patients' EF, aren't we doing them significant harm? So let's talk about that. So, in each of these studies, a few participants in each study did develop a drop in their EF. 9 total patients explored. So I know I said 7 during the trial, and there was 2 sort of in a post-trial analysis that developed a drop in their EF or under 50%. And 2 patients in Valor had a drop in their EF as well. In Explorer, they did say, the mean EF of the patients who did drop was still around 48%. So, not quite as low as the 30s and 40s, but under 50 anyway. They were all noted to have recovery EF, all except that one patient with the AF fibrillation. After the washout period, they all had an improvement back in their EF over 50%, but basically back to baseline. So, as Pioneer noted, there is a dose EF reduction relationship, but luckily this effect is reversible for patients who develop that reduction. And again, it's not most patients. It's a very small amount of patients in each group. So then sort of the moral of the story, in the spring of this year, mavacamten did get FDA approval for the treatment of obstructive cardiomyopathy in patients with NYHA class 2 to 3 symptoms. But, they have to be on some guideline-directed therapy prior to that. There's some approved doses here. And similar to the trials, the recommendation is to start on a lower dose, typically 5 milligrams, and then have serial follow-ups to make sure their gradients are improving, but also to make sure their EF is not worsening. And if the gradient's not improving and the EF is okay, you can increase the dose of mavacamten. Expensive medication here. Would love to, at the end hear Dr. Williams and Dr. Byland's experience on prescribing these medications, obtaining these medications for patients. But at least from what I could see, it's really expensive medication. But hopefully patients who have good insurance and meet their deductible after a month or so can have most of this covered. But the sort of the black box is advised not to start in patients who have a baseline EF under 50%. But if their EF is okay and you start this medicine, they need serial monitoring, probably every couple of months or so to start, and then stretching it out to every 6 to 12 months of the echo and looking at their EF to see if they're dropping their EF. And then quickly wrapping up with some future directions. So there's MAVA LTE study, which is taking the cohorts from the Explorer trial and watching them for 5 years to say, okay, do these effects, these great effects still remain in 5 years? And then also, what is the safety of this drug in 5 years? So as time goes on, we'll get more and more information, hopefully get more and more comfort in prescribing this medicines. Then there's Maverick HCM. So this is for non-obstructive HCM. So our very first patient who had non-obstructive disease, but really severe symptoms, really this was not studied in the prior trials that I talked about. So this is a phase 2 trial. Participants could remain on their therapies. They split them up into 3 groups: low plasma levels, high plasma levels, and placebo. And the primary endpoint was that same sort of either or endpoint that Explorer had. So the mavacamten group, here again, very small study, but the mavacamten group had an improvement in their biomarkers. So looking at NT-proBNP, the red is the higher dose, the blue is a lower dose, and the dashed line is a placebo. So we can see that there's this dose relationship again with a drop in BNP with mavacamten. There's also an improvement in troponin levels. So in this plot, they actually combined both mavacamten groups into one plot and compared it to placebo. And we can see that, for later on intervals, there is a significant decrease in troponin. Interestingly, there was no difference in functional endpoint. So there was no difference in that primary endpoint in this study between the placebo and the mavacamten groups. And then they also looked at echocardiographic endpoints because, in the obstructive group, you can use LVOT gradients as one of your variables. So they use, evaluations of diastolic function, and they assessed with E to E prime ratios and E prime velocities. And there was no difference when they compared the groups. However, when they sort of did a sub-analysis and looked at the most sick patients in each group, so the participants who had troponin levels over 99th percentile or EDA ratios over 14, in those patients, they actually did find an improvement in the mavacamten group. So 33% of the patients in the mavacamten group and 0% of patients in the placebo group met the primary endpoint. So, small study, phase 2, just again, looking to see if the drug works and is safe, doesn't show sort of that primary endpoint benefit at face value. But when they sort of dug deeper for patients who are sicker, mavacamten did sort of come out ahead compared to placebo. And then the newest new kid on the block is aficamten. This is a drug developed by Cytokinetics. Again, similar novel cardiac myosin inhibitor, similar to mavacamten. This drug, though, has a shorter half-life than mavacamten. And that becomes important because, it gets patients therapeutic and some help sooner. But also, if you have that drop in EF, you stop it and it's going to wash out a lot sooner than mavacamten. So that's helpful. And then dosing is comparable to mavacamten, starting at 5 milligrams. The phase 2 trials has really Redwood, and then Redwood OLE is the extension study. I'm not going to spend too much time on this, but similar to Pioneer, looking at sort of these outcomes in the phase 2 trial. And then, things are not published, but these findings are coming out. But starting at 2 weeks, the LVOT gradients in aficamten decrease in the treatment group. 61% of patients improved by one NYHA class, and 17% actually improved by 2 classes. There was an improvement in biomarkers. At least at 24 weeks, there was no drop in EF under 50%. Nobody had that. So, some promising data there. And then all domains of the Kansas City questionnaire are going up. And then that leads to Sequoia, a lot of sort of just California driven trees. I think Cytokinetics is based in California, but Sequoia HCM, now this is the sort of parallel to Explorer HCM and mavacamten. This is aficamten, phase 3 trial. So this is a multi-center placebo-controlled trial looking at similar outcomes compared to the mavacamten studies. There's a goal of being, the largest HCM trial with a goal enrollment of 270 participants. And excitingly, Emory is one of the participating centers. So if you have patients that have HCM, certainly, talk to Dr. Byland, Dr. Williams about enrolling patients in the aficamten study here. And then, possibilities outside of HCM, this kind of thinking and spitballing, would love other folks' thoughts too, is, LVH and hypertensive heart disease, it's certainly a different molecular pathophysiology and development, but with these inhibitors being primarily driven by inotropy and increased relaxation, wondering if this will ever sort of be applied to those disease phenotypes. And then diastolic heart failure in general from a variety of underlying etiologies, wondering if these inhibitors will be tested in those patients as well. So just wrapping up with takeaways of, treating patients with HCM and thinking about the at least guidelines that we currently have, use the echo, and then stress echoes as needed to determine presence of obstruction. If your diagnosis is sort of unclear, think about using MR. In terms of medications, the guidelines say, grab your beta blockers, grab the non-dihydropyridine calcium channel blockers first. If they have obstructive phenotype and they're still not doing well, think about disopyramide if they don't have other contraindications. And then if they still have persistence of class 2 to 3 symptoms, consider septal reduction therapy if you have access or if you're at a center of excellence, which fortunately we are here at Emory. And then now, it hasn't made its way to the guidelines yet because this is, just coming out, but we do luckily have an FDA approved medicine now called mavacamten. We might have another one in the next coming years in aficamten, which are showing really great benefits for patients. So glad to have these medications and help altering disease course. And then if you start it though, please monitor their echo serially to make sure that they don't drop their EF. A couple of really big thank yous. Dr. Byland was my coach throughout this. She's not only so knowledgeable on this topic, but is just such a great advocate for us as trainees, and really an inspiration and a big encouragement to all. So thank you, Dr. Byland, for supporting me through this. And, a much better talk than I gave is her grand rounds on YouTube. So if you just look up Hypertrophic Cardiomyopathy, a story in evolution, she gave wonderful grand rounds in 2021. And Dr. Robbie Williams, thank you for leading our Hypertrophic Cardiomyopathy program. Thank you for leading our fellowship. And then most importantly, thank you to my wife and my pup. For the last 7 weeks, I've not had any responsibilities at home as I put together this talk. So thank you to her as well. And finally, I'll stop talking. And I guess we can ask any questions, or if you have any compliments, you can pass it along too.
Well, Melroy, I'll start with a compliment. That was an excellent review. And thank you so much for that. Obviously, it's an exciting time in the treatment of patients with hypertrophic cardiomyopathy after many years of sort of beating our head against the wall in terms of medical therapy. Like you said, it's been an exciting past 6 months or so. For us, there are a couple questions in the comments. I guess I'll start there and then we can open it up to the group. I'm sure there's a lot to talk about. So Ifioma asks, Melroy, any trial exploring use of mavacamten earlier for patients in prophylactic prevention of hypertrophy in patients who are genotype positive but phenotype negative? Have you come across any of that data, Melroy?
So I know at least in looking at beta blockers, calcium channel blockers, the guidelines say if patients don't have manifestations of heart failure or limitations, they would recommend against starting those therapies prophylactically. I don't know if for mavacamten, if they've tried for patients who've developed this phenotype but don't have symptoms yet. Have not developed the phenotype but are genotype positive. I don't think that's been assessed yet.
No, not to my knowledge. I mean, I think this is a theoretical benefit down the line. I mean, there was a sub-study of Explorer looking at MRI data, and there was some LV mass regression in patients on mavacamten. So there's this thought that it actually does have phenotype altering properties. So maybe this is a down the road thing, but to my knowledge, and correct me, Dr. Pylon, if I'm wrong, Aslam, but no ongoing studies to my knowledge, but I think this is a potential theoretical benefit of this class of medications down the road.
Yeah, that's correct. There's no data. Congratulations, Melroy, by the way. Wonderful job.
Thanks, Dr. Pylon.
Steve Linderman asks, how often would you do the serial echoes on patients with mavacamten? Once a month for the first 3 months, Steve. It's required for them to get them. They're in a REM safety protocol, so we have to do an echo on them every month to assess their EF and their gradients, limited echo. But so 30, 60, 90 days, and then another one at six months, then every 6 months after that. So these folks have to get a lot of echoes. Mm-hmm. And where EF drops happening early versus late on single dose. In my experience, the EF drops are modest and they're pretty immediate. Again, Aslam, correct me if you've had a different experience. I've had one patient who had a dramatic EF drop, like a 30-point EF drop, but he went into AFib with RVR. And he actually felt fine. He came in for his echo. He's like, I feel great. And his EF had gone from, 60 to 25 or something. And he felt great, but we had to stop his mavacamten because he was also he had a history. He had known paroxysmal AFib and had gone into AFib. So, and this is a thing that others have mentioned. This is sort of a new, like that somehow tachycardia and mavacamten. So AFib and tachycardia and mavacamten seem to be not a great mix. And then Dr. Linevsky asks, disopyramide or mavacamten after beta blocker trial, which one first? So, I think technically still disopyramide would be your second line therapy, just because of cost and convenience, relative to mavacamten. But at least we now have another option if disopyramide is not tolerated or they don't get great symptom reduction. So again, Aslam, feel free to chime in if you have any other thoughts on those questions.
I agree. I think one important thing to remember is this medication is a negative inotrope. It's how the medication works. So we do expect to see a modest drop in the EF, about 5 to 6%, and that typically takes about a month. So, but there are going to be some patients who are going to be quick responders, kind of profound responders, and those patients might have an earlier drop of the EF, and they could have a more profound drop as well. I think it is important to have the right clinical support staff in your clinic, somebody who could be available to reach out to patients, ask about their symptoms. Maybe you could have your clinical staff give them a call in 2 weeks or so, make sure that they're feeling well. But in most of the patients, and this was shown in the trials as well, it'll take about a month before they drop their EF and have improvement in their symptoms as well.
Yeah, it's a good point. It's not really toxicity; it's sort of the expected effect of the drug. And anecdotally, it's been the clinical response to this drug for most patients is quite dramatic, as has been alluded to earlier in the talk. They seem to really respond well. Mon has a question. Mon.
That was an amazing talk. I learned a ton. I have actually 3 questions. The first question is a logistic one, and that is, how do you adjust medical therapy when you start this mavacamten? The second question is, can you predict response based on mutation? And the third question is, what would be the mechanism by which these medications would help diastolic dysfunction, diastolic heart failure in the absence of hypertrophic cardiomyopathy?
Melroy, you want to take any of those?
Yeah, so at least that last one, how does it help sort of diastology? I think by working as a negative inotrope, by causing less cross-bridging of myosin and actin, that helps kind of alleviate that hypertrophy, and then as we see, that also ends up with a decrease in LV mass. So I think by the negative inotropy sort of decrease in LV size and LV mass will help the relaxation component of the the diastolics. So I think that's primarily how that this can improve diastolic function. The question about are some genotypes maybe will be more responsive to this? I'm not aware of that, at least so far. I don't know if they've assessed this. I don't know if they've assessed this sort of in animal studies, but I think, a lot of the patients in this trial have probably a varied amounts of genotypes and seem to have good impacts on their phenotypes with this medication. So I don't know if there are sort of more like genotypes that are more responsive to this medication or not. And then I forgot your third question, Dr. Jokadar, sorry.
Adjusting the dose. I mean, go ahead. Yeah, adjusting the dose.
Yeah, I think, if their EF stays okay and their blood pressure is tolerating it, for my N of a few patients of Dr. Bowen's that I was looking through, they're already on sort of minimal doses of some of these guideline-directed therapies. So, maybe they would have to come off those medications because you're already adding a new negative inotrope with mavacamten. But I guess in your experience, Dr. Williams or Violin, have you adjusted, removed their beta blockers, calcium channel blockers?
There's a pretty strict algorithm based on what happens to the gradient in the EF in terms of, and their symptoms that we have to go through every month. And so we adjust their dose essentially on a monthly basis based on what's happening to their gradient, what's happening to their EF, and what's happening to their symptoms. Aslam, do you want to answer the question about, do you have anything else to say about any of those or the diastology component of it and how this might help for diastolic dysfunction?
So we don't really have data in patients who don't have hypertrophic cardiomyopathy. When we look at the patients with hypertrophic cardiomyopathy, this drug seems to be a lusiotrope. It basically improves the myocardial remodeling over time, and it decreases the remodeling biomarkers as well. But again, we have no data in patients who don't have hypertrophic cardiomyopathy.
Well,
and I guess I just wanted to make one more comment. So in terms of how to start the medication and how to adjust other medications as well, as you said, we have to enroll these patients into this REMS program, which is a safety program. You would typically, once you enroll the patients into REMS and adjust the mavacamten dose according to the REMS, if the patients are feeling well, then I have been either stopping or withdrawing other medications. And with that, I haven't had any problems so far. I did stop Norpace in 2 patients, and I was able to down titrate beta blockers in 2 other patients as well. And with that, they did not have any worsening of their symptoms.
Yeah. Generally, we stop disopyramide if they're on it when we start mavacamten, but you can continue beta blocker with the mavacamten.
Hey, Robbie.
Sir, we're out of time, but so quickly.
So like all other new drugs, we'll be looking for a pleiotropic reason to give this medication. And I was thinking about patients with aortic stenosis and hyperdynamic ventricles and those kind of things. I guess nothing much has come out on that yet, but I'm sure it's going to be in the future.
Yeah, you're right. I mean, I think potentially, a lot hinges on what this does. I think the diastolic dysfunction, obviously that opens it up to huge groups of patients, but right, any sort of condition where you need negative inotropy, it's a pretty clean negative inotrope without a lot of other, bradycardia or hypotension causing issues, unlike beta blockers or other negative inotropes. So
I have a quick question, if that's okay.
Sure.
It's a great talk, but do you know if mavacamten is cardio-specific? And if it is, what's the pathophysiology behind it?
Mm-hmm.
And if it isn't, then is there any detrimental side effects on other skeletal muscles? And how was it tested? Biomarkers, EMG, and etc.
Yeah, it's a cardiac myosin specific reversible allosteric inhibitor. So yeah, it's unique to the myosin, the cardiac myosin there. So there, at least I don't know if in animal trials they assessed for any changes in skeletal muscle, but I think cardiac myosin is fairly unique and contained to the heart. So yeah, I don't know if they did anything in animals, but at least in human, it seems to be just specific to cardiac myosin.
Yeah, I mean, I'm not aware of, and nor have I seen any skeletal muscle issues with this drug. It does seem to be very cardiac specific and free of really a lot of other side effects in my experience. So,
hey, Robbie, at $60,000 a year, I think I'd opt for surgery. Is there anything to help patients pay for this?
90,000 actually, Stan.
90,000. Oh, I'm sorry. I thought it was a cheap drug.
The drug company does have a program to help folks, but you're right. Cost is a major cost, and monthly echoes and a mountain of paperwork are all barriers at this point to getting this drug. So right. So at this point, septal reduction therapy is still a very viable treatment option for many, and one that many patients choose over this drug in my experience.
Gotcha.
I think the 5-year data from these extension studies will be really helpful, though, to then sort of compare the differences.
Long term, yeah. I mean, well, look, we could go on and on about this. It's a very exciting topic, and maybe one we can circle back to later in the year. And certainly, Melroy and Oslam and myself are happy to field any other questions offline. But for the sake of everyone's time, I know everyone's busy and's got a lot to do today, so we'll wrap up here. And thanks again, Melroy, for all his hard work and an excellent presentation. And we'll see everybody next week.
The preceding program is copyrighted by Emory University.